Doug Anderson. I'm an RN on the Surgical Intensive Care Unit. Today I'm going to talk about capnography monitoring and PCA, or patient-controlled analgesia use. I'm going to begin just with a review of a PCA pump in general. This here's a PCA pump, and this is the end tidal monitoring attached to it. Patient-controlled analgesia, it allows patients to self-administer their own pain medication. The limit's preset by physician. The parameters are programmed into the pump by nurses. Also, a basal infusion can be set to give the patient a constant stream of pain relief on top of the intermittent boluses. Just a brief review of carbon dioxide. Carbon dioxide is created from the breakdown of nutrients to create energy, or adenosine triphosphate, ATP. The process is influenced by different rates that can affect its metabolism, such as exercise, fever, infection, trauma. The way CO2, it's diffused from cells into the blood. From there, it attaches to hemoglobin. Some of it's dissolved straight into the plasma as bicarbonate. And it's important to remember the sodium bicarb relationship. If you were to give a patient sodium bicarbonate, you might see a transient increase with the capnography readings. For CO2 to be eliminated, it's simple diffusion, which means it goes from a state of high concentration to low concentration over the alveolar capillary membrane of the lungs through exhalation. The same way oxygen moves in, CO2 moves out. What does CO2 do exactly? It buffers the blood's pH. It regulates your respirations. It's a quick way to correct any kind of acidosis or alkalemia. If you're acidotic, you'd start breathing faster to blow off the excess C2, and if you're alkalotic, your respirations possibly slow down to increase your acidity level. So what is capnography? Capnography is a measure of carbon dioxide, specifically your end tidal. The way that works, it's either a laser light or infrared light that passes through exhaled gas. It could be side stream, which is less bulky. This is what will be used for the PCA pump. There's a slight delay. Another possible issue with this, besides the delay, is water can accumulate in the tubing, which will cause it to be replaced, or necessitates the need for replacement. Another way to measure it is mainstream, and this is for the endotracheal tubes. It's inline, it's bulkier, but it's instant. So a normal capnography reading, normal readings are 35 to 45 millimeters of mercury. This is your baseline. As you start to exhale, the CO2 will rise. During a normal expiration, you'll have a plateau here, and this is where our end tidal is read at the peak of exhalation. And then as you inhale during a normal reading, you'll see the CO2 level decline. Abnormal readings, these are different waveforms that you might see. In an asthmatic person, you can see the shark fin appearance. And this right here is just because of the restriction, just from the mucal plugging and just the bronchospasm. So your end tidal is still right here, but there's a lot of resistance going up. You don't have a steady plateau. Another issue you might see is hypoventilation. You might see some different waveforms. Eventually the acidity will rise, or the CO2 will rise, so you'll see a reading above 45. Both these, your respirations are slowing down. This one you have a longer period of exhalation. This one, just the expirations are a little weaker, so you don't see as prominent of a waveform. When you begin to hyperventilate, your CO2 lowers. You'll see an increase in the respirations, and then a slow decrease in your end tidal reading. So our primary concern with the PCA pump is going to most likely be hyperventilation due to sedation and apnea. So how do we use capnography? There's some different uses for it in the healthcare setting. Procedural sedation, airway placement confirmation, after endotracheal tube placement. If you're in the esophagus instead of the trachea, you won't see the end tidal, or you won't see carbon dioxide release be consistent. And then cardiopulmonary resuscitation. If you're doing adequate chest compressions, you'll see a end tidal of around 10. And it's a good indicator of return of spontaneous circulation. If you were to see a sudden spike in the level, it'd be a good time to check a pulse. And also, it has prognostic value. If you're staying at a low end tidal over about 20 minutes, then you could terminate the CPR attempt. And patient-controlled analgesia to monitor our respiratory status. So let's talk about combining the end tidal CO2 and PCA use. What we're trying to prevent is this OIRD or opioid-induced respiratory depression. Currently, we use pulse oximetry, which is actually a late indicator of respiratory compromise. End tidal will, due to the waveform, you can see the mechanics of breathing, and you'll have a quicker value to indicate that there's going to be some complications with the PCA use. So what do? To rest, you use naloxone. It's 0.2 milligrams diluted in 10 mils just for respiratory depression. Say there's kind of a little too lethargic, you'd mix 0.2 naloxone and 10 mils, and just give them 1 to 2 mil aliquots until they start to wake up. You don't want them. You don't want to suddenly give it and get a stress response from all their pain coming back all at once. 0.4 milligrams, a little higher dosage for respiratory failure or arrest. Here's my board of references. Thank you for your time.